let me just, thank you so much for the invitation and for your invitation to this meeting. Thank you to the organizing committee, Dr. Farouz and everybody else. Can you see my screen okay? Okay, great. So my talk today is a little bit different and perhaps a little controversial, but I wanted to talk about kind of an overview. Let me see here. Oh, it's not. Hold on. It's not. Oh, here we go. Okay, sorry about that. So I'm going to talk about an overview of the transgender surgical care, particularly in the United States, and the concepts to how we can evaluate these patients for facial feminization as may pertain to our practices. So first, we just need to define that sex is what's medically assigned to us at birth based on our packaging and chromosomes compared to the gender identity, which is kind of our inner sense or awareness of being a man, woman, or other. And if you remember in chemistry, transgender is, let me just see if I can remove that, is the opposite. So if we have a male at birth who identifies as being female, this is a transgender woman. Is this out of the picture here? There we go. Okay. So why are we speaking about this? This survey showed that in the United States, at least, many people, over 50%, are being denied insurance coverage for this type of procedures or surgeries. And even those that get covered cannot find access to the appropriate physician. And really, other studies have shown that medical schools and residencies are not educating or exposing our students and our learners to these issues. And although for trans women, hair removal from the face and changing their voices is by far more common, many of them will wish to have some sort of facial feminization at some point. And it's important to recognize that although this is purely aesthetic for many of these patients, for others, it actually may be medically necessary to alleviate gender dysphoria, which is actually a DSM-5 diagnosis. And there have been studies that shown that there have been improved mental health related QOL scores after facial feminization. So whether we decide to treat this ourselves or not, it's important for us to at least listen to the patient. Where are they in their transition? Are they wanting an early change, or something a little bit moderate or a little more dramatic? Recognizing that, of course, there are cultural and ethnic variations. And it's very important for us to consider hormone therapy first, because this will decrease facial hair, skin, and hair distribution and fat for at least even a year. And this is a book that is by Dr. Ousterhout, who popularized this procedure. So first we understand there are aesthetic standards, male versus female faces, horizontal thirds, vertical fifths. We're all very familiar with that. And what are the differences in these male versus female faces? So Spiegel wrote this article, which is very important, and he actually took photos, digitally altered them, and then gave them to observers. And they found that the observers graded any surgical changes. So they changed kind of the different parts of the face. They found that surgeries to the upper third were much more feminizing than anything done to the nose or the cheeks or their lower face. And why is this? This is because in the upper face, you have much more prominent frontal bossing, as we know, with the protrusion generally in the male forehead. This results in very prominent supraorbital ridges and low set brows. Now, if we get an X-ray plain film, we can see if they have a lot of frontal sinus. If they have a lot of or very minimal air in the sinuses and the ridges are not too bad, you can actually burr these ridges down, which is a type 1. If they have significantly more air and you're a little more concerned about burring, you can do a whole setback of the anterior table. And somewhere in between, you may be able to consider fillers in that kind of area of depression, very carefully, of course, being aware of emboli. So again, this demonstrates this supraorbital ridges that are very prominent. You can actually burr these very easily through an upper blepharoplasty incision. The glabellar frontal bossing is easier addressed, as you can see here, through a forehead lift. And you can see, again, this prominent ridge. And what this does is, as you flatten and contour it, it elevates the brows, creates a more feminized open orbit, and then you can simultaneously advance the scalp and change the hairline here from this male appearance. And as you also contour this central glabella, it flattens the nasal frontal angle. And what we mean by that is in the female face, this is much more obtuse compared to a sharper male angle. And so if you're flattening that, that makes it more obtuse, like a feminine face. Now, if a patient doesn't want to have surgery, you can consider camouflaging with a little bit of filler right here in the radix, although being very careful in that region. As mentioned, the male forehead height is quite similar, maybe a little bit higher, but they have a much more M-shaped pattern compared to a rounder shaped forehead. And this can again be changed with surgery, hair transplant, or again, excising and bringing the hairline together. We are very familiar with the eyebrows and the differences, and just kind of reminding that the eyebrow height should be higher in the female or feminine face, more arched, thinner tapered, and we can consider injections of botulinum to minimize the depressors in this region to help elevate that lateral brow. And for the eyelid, this is usually very important to these patients. And I find that they often want much more of a kind of smoky eye appearance, shadow, deep sulcus. So often increasing the height of the lid crease, taking a lot more fat out so you don't have as much of that hooding skin over the tarsal platform. So creating a deeper sulcus altogether is generally more favorable for these patients. Now, as we move on to the cheeks, the masculine cheekbones are typically wider, but they don't have the prominence and height of the feminine midface. And remember that the facial fat can change after starting hormones. So you do want to wait for that first. But this is an area that you can do fillers or fat augmentation above the malar bone to help elevate that cheek. Now, the other thing that is very easy and popular to do is actually debulking the malar fat. So you can see here, there's a lot of poochy chipmunk cheeks here, and that's malar fat. And if you want to create more of a feminine face with an oval shape, you can go through a gingival approach here and take out the malar fat, going through the buccinator, spreading, and then taking that very carefully. And that really helps kind of soften this fullness in the malar region. And then in the nose, I don't personally do the rhinoplasty, but keeping in mind that you're wanting more of a scoop here, and again, that more obtuse angle. Again, you can fill there gently, very carefully, but sometimes in the nose, you can see this angle here, again, very different in the male and feminine face. So this is a little bit more kind of upturned nose. So sometimes you can consider for some patients a little botulinum here in the depressor septi or LLAN, muscles to kind of decrease the flare of the nostrils and also to turn up the nose for some patients. And then, of course, in the lips, we want to think about generally if you're drawing a line from the chin to the tip of the nose, the upper lip and lower lip position, this is usually 2 millimeters difference here. You want to create more of a fullness in the upper lip, more kind of pink show. And in some patients, compared to the male, you want to shorten this space too from the subnasale to the lip. And you can just, this is just a technique to do this simply through a small incision, and that helps turn up the lip and create more fullness. These are many things that we can do in our repertoire. And then finally in the chin, this last portion here is the chin generally projects 2 to 3 millimeters posterior to the lower lip. Now in the gentleman, masculine face, you might get more kind of protrusion there, and this also results in a more deep mentolabial sulcus. So for those who may not want surgery, you may want to fill the mentolabial sulcus a little bit with a little filler carefully. Surgically, you can shave this down or at the jawline. Remember, the jawline generally is a little more sharper and squared off in a masculine face. And then other non-surgical option, of course, that we're familiar with is doing some botulinum toxin to the masseter muscle that can help soften these things. So these are all areas that there are techniques that we can do in our practice should we desire. But I just wanted to kind of mention that this is a more popular area of our field, and we can be skilled experts in these areas. It's important for us to understand the concepts so that we can provide competent care or refer properly to the right specialists if we choose not to do this. Thank you very much.